COVID-19. You're in for a real treat today, whether you're here in person or you're on our virtual session, because we have Dr. Jorge Mira, who I've gotten to know in the last 2.5 years since COVID hit. And he is one of the best teachers I think I've ever been around. So Dr. Mira is the director of the infectious disease program for the Cherokee Nation out in Oklahoma. It's the largest tribally operated healthcare system in the US. During the last 2 years, of course, his focus has been mainly in mitigating the effects of the COVID-19 pandemic in the Cherokee Nation, all the time trying to maintain their hepatitis C and HIV elimination programs. He completed his fellowship in infectious disease and clinical microbiology at the Baylor College of Medicine in Houston, Texas, and is board certified by the American Board of Internal Medicine and he has an infectious disease specialty. He's an associate professor of infectious disease at the University of New Mexico Health Science Center, as well as the ECHO Medical Director for the Northwest Portland Area Indian Health Board. He's a fellow of the American College of Physicians. So, Dr. Mira, we really welcome you and thank you for being here.
Do I need the microphone? I don't think you will need to speak. Oh, okay.
Okay.
Thank you very much. Thank you very much for the invitation and the organizers. Yeah. I will be focusing on adult patient management of COVID-19. Don't do a lot of pediatrics here. I do a little bit when needed, but far from being an expert in that field. If there's any questions, I'll try to tackle. Next slide, please. So, when I started preparing this presentation, I'm used to doing COVID echoes and we touch specific topics. Then suddenly I have to talk about COVID overall, and a little bit daunting. There's so much material out there. What do I choose? And I try to focus on more clinical things and situations that I recently in my medical practice. And that's what I'm going to be talking about. So, the clinical case, just to set us in context, and then I'll talk a little bit about epidemiology and transmission, clinical presentation, diagnosis, and treatment, what we have up to date. A little bit about prevention, and then long COVID has become a more frequent consultation in our clinics, and so I do want to mention a few things about that. Next slide, please. So this is a patient, Mr. T. He's a 36-year-old Native American male with a past medical history of well-controlled hypertension, who comes as a walk-in patient on your clinic on Friday at 4 p.m. We were really excited and happy about that. And he complained of headache, fever, and fatigue that started 4 days before leaving to your clinic. He is fully vaccinated for COVID-19. He has received 2 RNA vaccine doses, 1 booster given 8 months ago, and he is married and has 3 children. They're all vaccinated except for the 2-year-old who goes to daycare, and he denies any COVID-19 contacts. His family is always symptomatic at the time that he visits you, but his 2-year-old had a mild rhinitis 3 days before he came to your clinic. His physical exam, except for the fever, is really unremarkable. And his pulse ox was 95%. It's always important to mention the pulse ox because if this patient were to have COVID, that is one of the criteria that we use to see if the patient needs admission or not. And his labs, he doesn't have any labs on the when he visits you, but 1 month ago, he was getting followed up for his hypertension. He had a CBC and a CMP, and those were normal. And he did a home antigen test that day, and it was negative. Next slide, please. So I want you to think, I don't need an answer from anybody, and I don't worry, I'm not going to be pointing on anybody, but let's go over the options, and then we'll try to tackle them at the end. So what would you tell this patient? This is probably a respiratory virus, but not COVID-19, since he was vaccinated, his antigen test is negative, has not had any COVID-19 exposures, and you recommend supportive care and no isolation required. That's option A. Option B, he should be tested for SARS-CoV-2 with a molecular test. If positive, offering him antiviral treatment after labs are obtained. When I mention this, is you're probably thinking we'll get Paxlovate or remdesivir, and there's a renal function discriminatory decision there. And he should isolate for 5 to 10 days, depending on what his antigen test is 5 days after the symptoms start. Option C is the same. You should get a molecular test, and if positive, offer him antiviral treatment, though you don't need to perform in the lab. You just treat him with the history of the labs he had a month ago. Option B is he should be tested for SARS-CoV-2 with a molecular test. If positive, he should not be offered treatment because he does not qualify for treatment. He doesn't have enough risk factors to be treated. And the same precautionary measures. And option B is he should be tested for SARS-CoV-2 with a molecular test. If the test is negative, he does not have COVID-19, probably a different respiratory viral infection in your life. So this is a very common scenario that we get all the time, and I get a lot of questions. So these are the pieces of information. So I'm going to give you.
If I can interrupt for a second, the virtual attendees can hear you. Oh, wait.
Okay, I apologize to the virtual attendees. And we'll go from here. If anybody has any questions, if you can put them on the chat, I'll clarify them. Next slide, please. Next slide. Okay, so most of you probably know this information. We've had COVID for over 2 years now, and it's an RNA virus with a spike protein. The acronym is for severe acute respiratory syndrome, coronavirus, and SARS-CoV-2 is because we had a SARS-CoV before in 2003, and this is the second one of its lineage that causes a pandemic in this case. So we do know that bats harbor this virus, or very, very, very similar viruses. And we know that bats can give it to other animal hosts like the pangolin that's depicted on the graph. Well, we don't know yet if it's humans originally got it from a bat or if they got it from the mammal host. And that still has not been deciphered. Now this is not the first time that we have problems. I mean, severe problems, yes, but we are used to having coronavirus infections in our patients. We have the 4 that are outlined there with those letters and numbers, HKU1, NL63, et cetera. Some of them are seasonal, and they're mostly causing common colds, and we see them every year a handful of times. And they rarely, but sometimes cause severe pulmonary disease, and patients are admitted, but not in the magnitude that we've seen with COVID-19. And we've had 3 major epidemics / pandemics. The first one in 2002 with SARS-CoV in China, then MERS-CoV-2 in the Arabian Peninsula, and now COVID-19 that started in China, but it's worldwide. Next, please. So this is just to give you an idea of what SARS-CoV-2 lineages are circulating right now in the United States. This graph is updated until July 30th of 2022. And you can see that BA5 is the predominant Omicron sublineage that's circulating in our communities. And you can see when you look back in the graph on the dates, it starts in April, how rapidly these lineages change. So these are variants of concern. Variants of concerns are sublineages that either have increased transmissibility or increased disease severity, and the CDC and WHO are watching them closely. And the ones that the major one that's circulating is a sublineage of Omicron, which is BA5 and a little bit of BA4, but we still have a little bit of BA2 also running around. The burden of disease is enormous. Over 500 million documented infections worldwide, over 90 million documented infections in the US, with more than 1 million deaths in the United States so far. And next slide, please. So modes of transmission. So it's interesting, when I was preparing the talk, I was pulling my old slides and I got on my lecture that was 2 years ago and I had a big slide that said no aerosolization, only droplet transmission. Well, I was wrong, but I was just the middleman between the scientists and the public. So now we know that aerosolization has a role. It's still debated how important the role is in the big scale of, how many people get it from droplets and how many people get it from aerosols, but we definitely know that aerosols can transmit it. Definitely, a droplet is a mode of transmission, and masks protect you very well from droplets. Mask also protects you from aerosols, but it depends on the duration of exposure. So the longer duration of exposure in an aerosolized environment, the mask starts losing its protective power. The major problem is crowded and closed spaces. So we know that in an enclosed space, for example, this room we had a lot of people in here, that if there was one person with COVID, the risk of transmission is 18 times fold higher to other people compared if we were in an outdoor, well-ventilated area. And it all depends on the size of the room, the type of ventilation, the activity that the people are doing. If they're singing, that's highest risk of transmission. If they're talking a little bit less, if they're exercising a little bit more, and if they're watching a movie and nobody's talking, that's the best case scenario. The other thing is duration of exposure is critical. It's not the same thing to take a flight in a plane for 1 hour than a transatlantic flight for 10 hours and have someone with COVID-19 on the plane. And the other important thing is that the virus is mostly infectious before the patient develops symptoms and the first 2 or 3 days after symptom development. Next slide, please. So why is SARS-CoV-2 spreading so rapidly? And when I mean SARS-CoV-2, I'm talking about the latest sublineage, which is Omicron, and within Omicron, BA4 and BA5. So look on the right-hand side of the slide. First, it can be aerosolized. Second, the new variants apparently may have more intrinsic transmissibility, meaning the virus itself can adapt to the ACE2 receptor better. The ACE2 receptor is the receptor in our mucosal lining where the virus starts the infection, and or that it invades your immune system and starts infecting better than the previous strains, because with Delta, most of us are immune already. The other important thing is that there is asymptomatic transmission, and it can happen. Average about 17% of the cases are due to asymptomatic transmission, but it ranges from 4 to 40%. But I think the main problem is decrease of enforcement of prevention measures. So now here in this room, everybody's wearing a mask. Ideally, it would be great if everybody had been tested today with an antigen test and we were all negative. And that measure would really protect us from anybody here getting COVID-19 at a significant risk. Now, if you look at other viruses, measles has a reproductive number that is 15, meaning if one measles case will infect 15 other people. And COVID is now second. COVID was 4 or 5 a year ago, and it's climbed up to the second. It's not as bad as measles, but one COVID case can infect 5 other people. And I can vouch for this number. I was telling Harry that me, my wife, my daughter, her husband, and the 2 little kids were out on vacation a month ago. Unfortunately, we were exposed to someone not wearing a mask with COVID-19, and everybody except me got infected. So it infected 5 people out of 6 in our family. And I think I didn't get infected because I'm fully vaccinated, although the rest of the adults were, but I had Omicron 3 months ago. So that gives me an extra layer of protection. Next slide, please. So on this slide on the left, you can see this trying to depict the severity of disease. We think that this variant is less severe. Why? Because there's less hospitalizations compared to when we had the surge with Delta, and less deaths compared to the surge with Delta. Now, there could be 2 possible explanations. One is that the virus itself is less pathogenic, and there is some animal evidence that this could be true in experimental animal models. The other is that it's not less pathogenic than Delta, but people already have a certain degree of immunity that protects them, maybe not so well against infection, but it does protect them against severity of disease. And Omicron it's more transmissible than Delta. infects more household people than Delta, and unvaccinated and vaccinated individuals with Omicron transmitted more than with Delta. That is known. Next slide, please. So let's talk a little bit about predictors of mortality. So the main predictor of mortality is age. So the older you are, the higher risk of mortality. You can look in the graph on the right. You can see the different age categories and the odds, the hazards ratio of dying if you are in these different categories. So if you're 80 years or older, 10 times hazard ratio of dying than if you're younger. And then you have all the comorbidities, and they all have an impact, maybe 1 to 2-fold higher mortality, but not as bad as age does. So age is the main driver for mortality. Next slide, please. Yes. In this one in particular, I'm not sure, but I have a slide on race, ethnicity on the next one. I can't remember on this one if they controlled for that. I think they did, now that I remember, but I don't think Native Americans were a variable here. Right. But I think they did control for Black and Asian. Next slide, please. Oh, before we go to the next one. And you can see here in this slide that the hospitalization rates by age, stratified by age, the red is the older people, is much higher the older you are than the younger that you are. Next. So this is what you were talking about, race and ethnicity impact. And unfortunately, in the United States, Native Americans have 1.5-fold greater number of infections, 2.8 greater hospitalization, and twice greater deaths compared to white people. And then there's the other ethnic groups there, or racial groups, that also have higher mortality and admissions and hospitalizations, but Native Americans are affected the most. Now, why is this? We don't really know exactly. Nobody has shown that there's any genetic predisposition to dying more from COVID if you're Native American, but it could be a surrogate of other conditions like socioeconomic status, access to healthcare, living in more crowded conditions or situations, or more comorbid diseases. Next slide, please. Okay, so I'll stop here a second because this is an important slide. It doesn't have everything I need on it, but I'll try to walk you through it. So why do some people die and why some people have very benign infections? And we have an idea of some of the mechanisms. So when you get infected with SARS-CoV-2, the first thing that your body does is bring up the innate immune response. These are dendritic cells that recognize a foreign particle, which is in this case SARS-CoV-2, and they immediately start producing some cytokines, interferon 1 in particular, which is a critical cytokine to stimulate the rest of the immune system to kick in, and also to kill the virus that's infecting you. When that works well, your viral load goes down quickly, and you have probably a good outcome. When that interferon 1 response is not good, the viral replication does not slow down, and it stimulates your immune system more to a degree that you generate a cytokine storm, and some people die. Next slide, please. So here you have these macrophages or dendritic cells, and if they can control the viral load initially, you have a low viral titer, the immune response is adequate, takes care of the infection, and you survive. If it cannot control that viral load, the immune response is very aggressive, and it ends up accidentally killing yourself. Next slide, please. And next slide. Okay, so I think I missed the slide, or maybe I misplaced it, but there's another study, and maybe I have it later, that looked at, okay, we know that people who die do not have a good innate immune response, but why does that happen with age, or why does that happen with obesity? So some people have found that patients who die of COVID-19 have low interferon responses, have autoantibodies that block that interferon response. And in some, it could be genetically determined. Okay, so primary symptoms of COVID, you will know them very well. Fever, cough, shortness of breath, myalgias, etc. Fever and cough are probably the most common symptoms, but they're always present on day one. So it's not infrequent that we see just patients with headache and myalgia, and then down the road, they start developing the other symptoms. The laboratory finding that I find most commonly present, and especially in hospitalized patients, sicker patients, lymphopenia. So that's when they call me, I have a patient with a pneumonia, COVID test is negative. I always look at the lymphocyte count. If the lymphocyte count is low, I started having higher suspicion that this could be COVID. And of course, if they have ground glass opacities, that adds another layer of diagnosis. Next slide, please. Can you do one more click? Yes, okay. So that red line I drew, this is the NIH guidelines classification for clinical spectrum of SARS-CoV-2, and has a very practical use. Above the red line, people are sitting well, pulse oximeter 94% or greater. They may have a respiratory infiltrate, but it's less than 50% of both lungs. And those people are maybe candidates for treatment, but a different algorithm of treatment. Now, if you're below the red line, meaning your SAT is less than 94%, you are breathing 30 times a minute, or your lungs are covered with infiltrates, you need to be put on the hospital, and the line of treatment is a little bit different. So that's the first thing that you need to decide when you're seeing a patient. Do I need to put them in the hospital or not? Next slide, please. So you see a patient with symptoms like Mr. C, and then the next thing is you're going to do a test. So who do you need to test? Obviously, anybody with a respiratory symptomatic respiratory infection, anybody who has been a close contact of someone with COVID-19 and could have been exposed, and anybody who's traveling before and after travel, it's recommended that you get tested. And then there are certain surveillance or vigilance. When the community activity of COVID is extremely high, it may be worthwhile to test asymptomatic people periodically to detect the positive ones and put them in isolation or quarantine, depending if they're symptomatic or not. And that could be a control measure. Next slide, please. So let's spend a minute or two here on this slide. So let me go here, it's easier for me. So this is onset of symptoms is right here. There's a pre-symptomatic stage. The first thing that pops up lab-wise is your viral RNA, your PCR. Immediately after you start having symptoms is the antigen test that goes up and down. But if you correlate culturable virus, that means the patient's infectious. If you can culture the virus is quote unquote alive and can infect other people. And you can see how well the antigen correlates with the culturable virus. So the antigen utility is if an antigen is positive, that patient's probably infectious. Now, it doesn't mean that if the antigen is negative, they don't have COVID, because the PCR could be positive. But that's the beauty of the antigen. Now, the standard of care, if you suspect COVID, you have to get to a molecular test. They have the highest sensitivities. But to see if they're infectious or not, of course, if they're symptomatic, they're probably infectious, especially in the first few days of symptoms. But if to follow up on infectiousness down the road, like when do I pull this fellow out of isolation? The antigen test is the one that will help you there, not the PCR. PCR can be positive, look, all the way down here, even up to a month after and we've seen patients positive for several months, a handful of patients. Next slide, please. So this is from the Infectious Disease Society of America. They looked at a reference test, which was a PCR combined with clinical information. So everything was compared to that reference. And this is a standard PCR done in a lab that takes several hours to do. They compared rapid tests, which include PCR, like a film array has a rapid PCR, Cepheid has a rapid PCR, and there are several others. And the isothermal PCR, which is the Abbott test, the Abbott ID Now. And they also looked at the antigen. They looked at BioNext Now. There's tons of antigen tests now in the market, but that was the comparison that was done back then. So when you compare the rapid PCR, Cepheid, film array, et cetera, 97% sensitivity compared to the standard. When you go down to ID now, Abbott ID now, or any isothermal PCR, 81% sensitivity. And when you go down to antigen, it depends on the day's duration of symptoms and this presence or not of symptoms. So when someone is asymptomatic, an antigen test, only 50% sensitive to detect COVID-19. Antigen tests are good when they're positive, and you're probably most likely infected, but they do not rule out COVID if they're negative. Okay. Next slide, please. So this is the CDC antigen testing algorithm. And I'm not going to go through all the arrows right now, but you have that as your reference, but I'll give you two or three highlights. If you're asymptomatic or symptomatic, if your antigen's positive, that patient has COVID, unless there's a lower likelihood of infection in the community, like the levels are very low, and you have a positive antigen test on an asymptomatic individual, maybe that could be a positive test, and maybe that could be a false positive test. But for all practical purposes, a positive antigen equals you're infected. And if your test is if you're asymptomatic or symptomatic and your test is negative, the two variables that you need to consider is the patient fully vaccinated or have they had exposure? If they're fully vaccinated and no exposure, you're done with your testing. But if they have not been fully vaccinated or they have been exposed, you have to do a nuclear test. And even if that test is negative, it doesn't rule it out. And depends what test you're using. So you may need to isolate that patient quarantine, depending on symptoms or not, or isolate for 5 days. Yes. Yeah, right now, fully vaccinated would mean that you have all the vaccines that you're a candidate for. Like second booster, if you're over than 50 or you're immune compromised, you're a candidate. But if you're 40 and you're immune competent, you're not a candidate for a second booster. So you would be considered fully vaccinated with one booster. Yeah, that's a great question. Yeah, so we take. Right. So always fully vaccinated is you took all the vaccines that you're a candidate for. And that in the timeline, like maybe you're a candidate for a booster, or a second booster, but you're not there yet. You need one more month. You're still considered fully vaccinated. Next slide. A couple of other things. If you're going to do a confirmatory PCR on a negative or positive test, you have to do it as soon as possible. Do it the same day. Don't wait 3 days to do it, because it could be negative by then and it was positive the day you were supposed to do it. Another question that comes up, hey, Dr. Mira, I have a patient with a a positive antigen, and we did a PCR, I'm not sure why, and a PCR was negative. What do we do? So the golden rule is you take the confirmatory test as your final result. Now, that's the rule. I always ask, how were the samples obtained? Who did the same person obtain both samples? Were they done at the same time? Because if you're telling me, no, they were done the next day by a different person, the intensity of the swabbing may make a difference on a positive or negative. But the rule is that you use the confirmatory test. That result should be guiding your therapy. Next slide, please. So we talked about community levels, and this is interesting, and that's why I bring 1 or 2 slides on this. At the beginning of the pandemic, the CDC was making recommendations based on transmission levels, meaning what percentage of patients who were tested are positive. And then as the pandemic evolved and we had people vaccinated and people with previous infections, they noticed that the transmission level did not correlate with severity. Like, it doesn't mean because there's high transmission, a lot of people aren't going to end up in the hospital in the next 3 weeks. So to get a better measure, they looked at many variables. They did a really cool study. But what they found out is that new COVID admissions per 100,000 population or percent of staffed inpatient beds occupied by COVID-19 patients was a better predictor of what's going to happen in the following weeks. So when they hit certain levels that I'm not going to go through them in detail, but they're there in the chart and they're in the CDC website, that is when you decide to change your measure recommendations. Now, nothing is totally enforced except in a hospital. But for example, in our hospital, if you're in red, you shouldn't go to lunch together with anybody without the mask on. Everybody should be wearing a mask, etc. So you change your recommendations based on these levels. And next slide. And the next slide is the impact. So COVID community levels can inform recommendations regarding masking, testing strategies, how to manage people in households, what to do in schools, etc. So for example, where I work, when we hit the red, first masking is enforced everywhere, not only on patient care. And we start testing with antigen twice a week, everybody, to try to quarantine the people who are positive and decrease the risk of transmission. But that's, those are the interventions we do, and they can vary. Next slide, please. Okay, so I really love this graph because it gives you a good depiction of the evolution of COVID. And you start on the left with when you get infected, and that's the part of early viral replication. And can you click one slide? And that's where the use of Paxlovate, remdesivir, the monoclonal that's useful, and the time and molnupiravir are useful. Then when you start hitting the middle of the graph, people start getting short of breath. That's fine getting short of breath. I think I'm short of breath right now with the mask that I'm wearing. But as long as my pulse ox is okay, you're okay. But when your pulse ox drops below 95%, one more click, please. Then it's when that patient needs to be in the hospital, and then the treatment strategies change. It's dexamethasone. I think I forgot to put remdesivir there. Remdesivir is also a treatment there. Tocilizumab and baricitinib are options. So this gives you a good picture of the evolution of COVID. Now, thank God, not everybody gets to this stage. The majority of patients will be on that left-hand side of the slide. Okay, so this is the treatment guidelines, and I'll review them with you quickly, but I'll make some points more on the one that we're using the most. So first, who qualifies for treatment? You have to have, in general, you have to have COVID, and you have to have documented COVID with a test. Now, let me step aside on that definition. Sometimes I get called and a patient has a fever, a headache, myalgias. They did a CT, they're in the ER. They have ground glass opacities. The COVID test is negative. The PCR is negative. I ask them, do a film array for other viruses. All the other viruses are negative. They have lymphopenia, and that smells like COVID. And we know that even the lab-based PCR is not perfect. So very rarely, I will treat a patient with the patient's permission after I discuss the situation with them for COVID, even if the test is negative, if the clinical picture is very compelling. But in general, you have to have a positive test, either an antigen or a PCR. Antigen is enough. You have to be symptomatic. You can get away from that, and not hypoxic, meaning hypoxic defined as SATs below 95%. Now, remember, sometimes what happens is a patient gets admitted for an appendicitis, and they test them because everybody gets tested for COVID when you come in, and they're positive. You go back to the patient, and yeah, he's been feeling fatigue for 4 or 5 days. Sometimes difficult to tease out from the appendicitis. But you may treat that patient if you find that he could have a COVID-like symptom and he is within that 5-day window, even if he's hospitalized. But you don't treat him as a hospitalized patient. You treat him as an outpatient in the hospital. They have to have a risk factor for progression. Now, you saw the slide I showed you about Native Americans having a very high mortality, and the FDA gives you the option that you can use race and ethnicity as a risk factor for progression. So where I work, everybody's at risk for progression. Now, having said that, if you see a 20-year-old athlete, healthy, no comorbidities, normal weight, who is Native American and comes in with COVID, you can have a discussion with them and tell them, look, your risk is very low except for being Native American. Oh, and fully vaccinated, but you're fully vaccinated. The risk that you progress is extremely low. I'll offer it to you. I'll offer you the treatment, but it's your decision to if you want it or not, because you're at really, really low risk. But that does not apply for a Native American who is maybe 55 years old, even if they don't have any other comorbidities. Then they may be at higher risk. So you need to titrate that. And one thing that's very important to mention on treatment is that all the treatments, studies, all the clinical trials that were in which FDA based their approval were done in non-vaccinated individuals. We really don't know what the impact is of these treatments in fully vaccinated individuals. Now, having said that, when you look at the mortality curves, you'll see, let's say, 1,000 people die of COVID. And when you look at the risk factors, when you look at their vaccination status, out of the 1,900 were not vaccinated, but 100 were. So there's still people that can die even with full vaccination, and especially if they have risk factors. So I just want to mention that because the decision today is not as clear cut to treat as it was a year ago. But I do offer everybody who has a potential risk factor treatment and explain to them, we don't have all the data right now, but the medications are fairly safe. And I'd be happy to give them to you if you're willing to take them. So the NIH recommends 4 drugs in an order of preference. And let's do it on the next slide. I have them better, I think. Yep. So the first one is Paxlovate, which is nirmatrelvir ritonavir. Just remember that the ritonavir doesn't have anti-COVID-19 activity. It's just to boost the levels of the nirmatrelvir up because they're metabolized in, say, cytochrome, and you get good levels of the antiviral. You have to treat patients within 5 days of symptoms. 6 days doesn't work, but the sooner you treat them, the better. If you can get them within 12 hours of treatment, and I've had personal experience of treating patients, like the family example I gave you, treating all the adults like 6 hours after they started with symptoms, and this is observational, but they all recovered really quickly without not major symptoms. So the sooner you treat, the better. We'll go over Paxlovate a little bit more on the next slide. So I'm not going to go over the other ones. Remdesivir is a great drug, but it's IV and it's 3 days infusion. So it just takes a little bit of more logistic challenges, but it is a good option. And you can see 87% reduction in hospitalization and death. Very similar to nirmatrelvir, 88%. The reason the NIH puts remdesivir second is because it's not oral, it's more difficult to deliver, and that's the only reason. The third one is the monoclonal bebtelovimab. It's the only one that works against the strains that we have circulating right now, but we don't have good data on clinical efficacy. We're assuming it works well because the other ones we had before worked well, but on this one, we don't have great clinical data. And the last, molnupiravir, we have good data, but the efficacy is 30%. It's not as good as the other two, the other options. Yes. Yes. Yes, molnupiravir, it's an IV push. You do it outpatient, you observe the patient for 1 hour. Remdesivir, it's a little bit faster. You can give it in 30 minutes, but you still have to watch the patient for 1 hour. Now, interesting, that hour observation, I participated in the clinical trial of remdesivir. And in the protocol, we did not have to observe the patients for 1 hour. So I called the FDA. I said, why are you putting this rule? If the study that you evaluated to approve the indication, we were not, and they never answered me. And I sent them 2 or 3 emails. So anyways. So where do we do it? Outpatient. Yeah. So outpatient is 3-day infusion, and we do it in the, so this is the way we work it. Some patients come to the ER, and for Paxlovate is our first choice, but let's say Paxlovate, you can give it for whatever reason. Then remdesivir is the second. I tell them, give them the first dose if it's not a weekend, and send them to our clinic. We'll give them the second dose and third dose in the next following days. You could do it at home also. In the protocol, in the research study, we had patients that nurses went to their homes to deliver the infusion. So it's a little bit more complicated, but it's doable. And you do not need to hospitalize them. And last but not least, okay, the other difference is look at the days. So the nirmatrelvir and molnupiravir, the oral ones, 5-day window. The monoclonal and remdesivir, 7-day window. So sometimes we have to choose patients on day 6. Okay, they're out for the oral ones, but we can offer them the other 2. And the molnupiravir, it has some problems of you shouldn't give it in younger than 18. You should not give it to pregnant females, and you make sure they don't get pregnant because there may be some teratogenic effects that you need to be aware of. The only drug here on all this list that you can use in less than 12-year-olds is remdesivir IV. That's the only option we have for outpatient treatment. Next slide, please. So I'll spend one more slide on the nirmatrelvir ritonavir because it's the one that we use more frequently. It's the oral pill. So it comes in a blister with 3 pills, 2 nirmatrelvir, 1 ritonavir in the morning and the other at night. A couple of tips: make the patient take it with food or they'll get nauseated. We take it with food, hardly anybody gets nauseated. They will all have metallic taste, all 100%. So just warn them, and that'll go away after they finish the treatment. There are a lot of drug-drug interactions. You need to do a drug-drug interaction checker. The one that we use the most as clinicians is the Liverpool COVID-19 drug-drug interaction checker, but there's many out there. It's just user-friendly. And there is a renal pack. So if you have a GFR between 30, above 30, but less than 60, you have to give a lower nirmatrelvir dose. And that comes in a special pack that only has 2 pills instead of 3 in the morning and 3 in the evening. Or if you don't have the renal pack, now we were getting it, but now we're not getting any more. You just have your pharmacist take out 1 nirmatrelvir from each blister on each dosing schedule, and then you have the same dosing. So there's a lot of medications you have that interact with it. You have to do a drug-drug interaction. Some medications, let me give you a quick tip. You can stop them. You can stop a statin in some cases for 5 days. You can stop sildenafil if they're taking it for sexual dysfunction for 5 days. You cannot stop tacrolimus for a transplant patient. So some you can stop, some you can't, but discuss this with your pharmacist. Next slide, please. Okay, prevention. Let's go to the next slide. So we have non-pharmacological measures, which I'm running a little bit out of time. So I have time. Okay. Oh, okay. So the non-pharmacological measures, we kind of discussed them already. So it's, rapid identification of infected individuals, so you can either isolate or quarantine them. 6 feet of social distance. Now, 6 feet is ideal, but 9 feet is better than 6, and 3 is better than 1. So the more distance, the better. And there's good studies that demonstrate this increase in risk according to the distance. Now, if you cannot avoid crowds or indoor spaces like we are today, you have to wear masks. N95s are a little bit better than surgical, and surgical are a little bit better than the cloth mask, but cloth is better than no mask. Yes. What type of filter? I'm not familiar with that one in particular, but I can look it up and send you an email. Yeah, there is a lot of masks out there with a lot of variations. What I always look at if it's FDA authorized for medical use, because some are authorized for work use, like they're good for when you work with dust particles, but they may not be good for medical use, especially if they have valves, because some of those dust particles you can breathe out and you would infect other people. Maybe you'd protect yourself, but you wouldn't be protecting others. But I don't know that one in particular. Okay, of course, wash your hands frequently. As you're a healthcare worker, use full PPE, including eye protection. And then you have some pharmacological preemptive interventions. There's one monoclonal combo that we have, which is tagexigevimab and siljevimab, which is Evusheld. You may know it more with that name. And that is still working for the variant that's circulating right now. And you can give it to immune-compromised individuals or to people who cannot receive a vaccine with a good medical reason of not receiving a vaccine. You shouldn't do it for someone who doesn't want a vaccine because they don't believe in vaccines, because the recommendation is for people who have like anaphylaxis due to a vaccine, okay? And that'll protect you for 6 months, and then you can redose it. It's an IM injection, and you can redose it every 6 months. And it decreases, there's good data that decreases the risk of COVID-19. Next. Okay, any questions on vaccines? We have Harry here. Don't ask me any. This is just a brief summary that we have adult vaccines. We have 4 vaccines. 2 are RNA messenger vaccines delivered in lipid nanoparticles. One is a DNA vaccine in a vector, which is adenovirus 26. And then lately, like a month ago, we got, or a couple of weeks ago, we have a recombinant protein subunit, which is Novavax. So probably the best data is on the first two vaccines, on the first RNA vaccines. And actually the third vaccine is really not recommended anymore unless you have a contraindication to an RNA vaccine. Maybe you had an anaphylactic reaction or something. But the Novavax, it's a little bit less efficacious than the RNAs, but the main purpose of it is that some people who may not want RNA particles injected in their bodies may say, okay, I'm okay with a protein subunit and I'll take that vaccine. And the RNAs have two boosters. The Novavax, no boosters approved yet. The pediatric primary series, we have the RNA vaccines. And then for immune compromised individuals, we have third doses recommended. And basically they are the RNA vaccines. And that's all I'm going to give you on vaccines, except one more thing. One more slide, please, on vaccines. Do they work? Next slide. And there's several articles out there. I just chose one of them. And you look at this graph, and this is people, and this is hospitalizations per 100,000 population. This is Delta, and then here we start with the Omicron period, and you can see for unvaccinated individuals how the hospitalization increases. For people who have completed primary series but no boosters, it also increases, not as bad as this though. But then the people who have full vaccination, it increases just a little bit. So the vaccines work. There's no question that they work. They decrease deaths, they decrease hospitalizations. They may not decrease infections as good as they did, last year. When they came out, 95% protection. Now it's 30 to 40%, depending on what you're looking at. But there's no question that they work. And there's multiple studies done in different scenarios that show basically the same data. Next.
September is specific. Have you heard anything about that?
Yes. So the FDA, they came out with a recommendation that the next booster should be bivalent, meaning it has two components to the vaccine. One is the Wuhan strain, and then the other one's a BA5. I think it's a BA5, right, Harry? I know there was one manufacturer, I think it was Moderna, who already had a Wuhan BA1 ready to launch, but the FDA recommended a BA4 or BA5 component. So it'll be ready in November. Oh, that's what they said. So, maybe sooner, maybe later, but yes, that would be the recommendation for everybody who can receive a vaccine to get a booster dose if they're due for a booster at that moment. Now, a question I get asked frequently is, right now, what do? I'm due for my second booster, but the new booster is coming. Well, I try to live in the present, grab the booster today. We'll think about when the other one comes out and if you're a good candidate for it or not or whatever. So right now, the fourth booster, if you're due for it, the second booster, if you're due for it, get it now. You still have several months to go for the next one. Next. I don't know, Harry, if you think more or less the same.
Yeah.
Yeah.
But, just go ahead. If you do purpose, get the booster that's presently available. So, the latest rumor is that by late September, there's going to be this new Biden as a booster. But, we've all seen comments that said, oh, this will be all like this coming. It turns out to be. The other thing is we don't really look where the evidence is. And I've kind of been surprised on the current again just going on. I'm like, no, okay, let's be advised. So
Yes.
And people aren't learning that.
and people are just tired.
Yeah.
Yeah. Yeah, I agree. People are tired and politicians are still being politicians and they're not making medical recommendations. Well, they shouldn't make medical recommendations, but they should have their doctors make medical recommendations or their epidemiologists. Okay, so let's go back to our case based on all what we've discussed briefly. So the first one is not correct because this is the patient only had an antigen test. We know that sensitivity in symptomatic patients, best case scenario is 74% or so. So a molecular test is warranted for this patient. Now, the second option was, if positive, give him antiviral treatment after labs are obtained. So this is, I mean, this could be a good answer too. On an individual who has good, well-controlled hypertension, no other comorbidities, they had a renal test a month ago. I don't expect the renal test to be out of whack now. And I don't need to put them on that burden of, let's get the creatinine and then we'll treat you. I just rather go ahead and treat them. The risk of him having a creatinine of over 2 or 3 are very low. Now, if I see a diabetic person or anybody who's had a history of chronic kidney disease, on those, what I do practically, I get a creatinine, I send them home with the Paxlovate, and I tell if there's no drug-drug interactions, and I tell them, I'll call you if we need to decrease the dose. When I get the creatinine back that same day, I look at GFR. If it's fine, fine. If it's not, I call them, pop out one matter of your pill from each thing, and you just decrease the dose. Or stop it because you can't take it, come back, and we'll give you another option. Because you have to try to be practical, or else patients won't get treated. Option C, I think it's the best one, but B could be an option. Option D, that he should not be offered antiviral treatment. So I wouldn't say it's completely wrong because what I told you, if you're fully vaccinated, there's really no data on how good these antivirals will be, but it is still a recommendation to treat patients and to offer the treatment. So I would offer the treatment, but if the patient declined, I think it would not be unreasonable. And option E, if the molecular test is negative, he does not have COVID-19. That's not absolutely true, because if you have a high suspicion that the patient has COVID, you should send out a PCR to confirm the test, because we're doing in-house molecular, which is rapid test, and they're good, but they're not perfect. Next slide, please. Okay, I'm going to go through long COVID fairly quickly. How much time do I have?
We have 20 minutes.
Okay, no, I think in 10 minutes I can get it through, and we leave some 10 minutes for questions if there are any. So the first thing is the terminology. You can see that's been called everything, and that's fine as long as we all understand. When I hear long hauler, long COVID, chronic COVID, I know what people are talking about, but the most accepted definition is terminology. I'm sorry, it's post-acute sequela of SARS-CoV-2 or PASC. That's the most accepted one, but I think any of them are fine. The WHO has a definition which says broad range of symptoms, physical or mental, during or after COVID-19 that continue for more than 2 months after the 4 weeks of the initial illness are over. So actually for 3 months or after 3 months of illness. So if you have COVID today, by WHO to call it long COVID, you would have to be sick on week 13 and or not feel well week 12 and after that. It has to have an impact on the patient's life, and you cannot explain it but any other diagnosis. And this is important. I've seen patients come with fatigue, and actually what they had is sleep apnea, and they've never been tested for it. So you start out, I snore at night, I fall asleep watching TV, and for how long? Oh, about 2 years ago or 3 years ago. So make sure that you're not missing something else, or they have hypothyroidism, or that's why that last point is important. Next slides, please. So the WHO has a definition that I just mentioned. The CDC is a little bit less strict. If after 4 weeks you're not feeling well, you have long COVID, okay? I'm not sure which one to take, but I'll give you some guidance on the next few slides or what to do anyways. Next slide, please. So this is just to show, on the blue line is the number of COVID-19 surviving cases, and on the red line is the estimated long COVID cases. So, in this estimation, you have 20 million people in the US as of today who would end up with long COVID. Now, some people said the estimates are lower. It's between 1 to 5%. But even if you go to 1%, you're talking about 6 or 7 million people with long COVID, which is a lot of people that will have problems working, feeling well, and having medical complications. So the US government and accountability offices, they give 7 to 23 million. But even if you're on the short side, it's a lot of people with problems. Next slide. And the mechanisms is not well understood, but I would say that there's been a lot of theories, and some of them are immune dysregulation. It's like, you don't generate good interferon one, you don't get as sick enough to die, but you have that chronic inflammation persisting in your body. Some people say there may be some viral particles that are left, remnants that are triggering your immune system. Some have other, endothelial dysfunction, metabolic dysregulation, bed rest deconditioning. That's a pretty powerful one. People are fatigued, they lay low a lot, and that causes more medical problems and more fatigue and more deconditioning. And that's something that you could intervene with. And I'm not going to go over all the symptoms. They're practically affects everything. The ones that I see in my office more frequently are the cardiovascular, especially tachycardia and palpitations and chest discomfort. Fatigue is also a big one, and then anxiety. Next. There was one very interesting study, the one on the left-hand side. They did a prospective, they started a cohort of people with COVID, and they followed them, and they looked at the ones who developed long COVID and the ones who did not develop long COVID, and they looked at many things: symptoms, plasma, blood tests. They looked at viremia levels and other infections and autoantibodies. And what they found is that people with long COVID, the major risk factors were type 2 diabetes, having a high viral load for SARS-CoV-2. Interesting, Epstein-Barr virus reactivation, which is already associated with chronic fatigue syndrome, and certain autoantibodies, type 1 interferon antibodies, which I was mentioning at the beginning, and some antibodies associated with lupus. So these are associations. These are not causal effects, but this is where the research is going. And then in other studies, gender, females have higher odds ratio. So what I've seen is this, and what's published. Females tend to have females who had milder COVID-19 tend to have a lot of long COVID more than males, but males who were really sick tend to have also a different type of long COVID complications, more respiratory problems than the females. The females is usually tachycardia, palpitations, and chest discomfort, very common. If you have more comorbid conditions, higher risk. If you're older, higher risk. And if you had a very sick COVID-19 episode that you were hospitalized, higher risk of long COVID. But the fact that you were not in the hospital does not mean you cannot have long COVID. There's a lot of those that were never hospitalized. And one important thing I have it on a slide, I think, is that when you do evaluate the patient, even if you don't find anything objectively wrong, do not disregard the diagnosis. They can still have long COVID without objective evidence of it. Next. So this is just to show that people hospitalized have long COVID and people non-hospitalized also have long COVID. And that the major symptoms in the hospitalized ones is usually psychological and fatigue. And on the ones that are non-hospitalized, the psychologicals are the more predominant, but it could really affect any organ system. Next. So what do we do lab-wise? It depends a little bit. This is just a big, broad rule because someone comes for fatigue, it's a little bit different than someone complaining of shortness of breath or someone complaining of palpitations. But in general, what we do, we follow this guideline. We do a CBC, a CMP, we do a CRP, we do thyroid function. We look at C-reactive protein, vitamin D, and BNP and troponin. BNP just to make sure that the fatigue is not due to CHF, because a lot of people could have CHF for many reasons and aggravated by COVID. We do a D-dimer because you don't want to miss a PE. Although they're very common during COVID, there are case report. There's series of PEs happening after the week 4 of COVID infection. And we don't do anti-nuclear antibody because I just don't know how to interpret them. And I'll say, let's leave this for the last, maybe a couple of months from now. And serology only if you don't have a documented COVID infection in the past and you really want to know if the symptoms are related to COVID or not. Next. So if the patient doesn't have anything serious, just hold their hand, wait, give them some comfort measures because in the majority of patients, all this will go away. But you need to make sure they don't have nothing serious. That's the trick. Next. And vaccination is very important. That's another reason why we should vaccinate our patients. If you vaccinate them, they have low risk of COVID-19, of long COVID symptoms or past symptoms. Although the ones that predominate, even if they're vaccinated, are the mood disorders, anxiety, depression. You can see everything on the right of this line is that the vaccine did not protect you from. Next. So first, long COVID should be initially managed by a PCP. Do not refer patients to specialists unless you have a very specific cause. Provide understanding and support. Hold their hand in a good way. Identify comorbid conditions that may have been missed before COVID, or maybe have been exacerbated, like sleep apnea, hypothyroidism, CHF, etc. Try to tackle, don't disregard the symptoms. They have sleep disturbances. Work with your usual toolkit for sleep aids with these patients so they can sleep better, etc. Next slide. But the message I want to give you, you need to make sure you don't miss a couple of things. So what I don't want to miss on someone coming on week 12, short of breath, is that they don't have organizing pneumonia, pulmonary fibrosis, a PE, pulmonary hypertension, or a fungal pneumonia, which is extremely rare. So we do a chest CT, we do PFTs, we do a 6-minute walk in the clinic, we do an EKG and echocardiogram. All these tests can be ordered by a PCP. You don't need a specialist for this. Now, when you get the results back, if the patient has PE, you can anticoagulate them. If they have pulmonary fibrosis, then you may need a pulmonologist. If they have a coronary artery disease, then you may need a cardiologist. But do this first evaluation yourself, because the patients will be better under your care than with multiple referrals. Next. If they come with chest pain or palpitations or postural tachycardia or dizziness, and I'll explain that a little bit more. When you look at this graph, it's troponin, BNP, EKG, echo, stress test, all these tests you can do. You can order, get them back. Then basically you have to say, when do I refer this patient to cardiology? And that's a good outline. Abnormal cardiac text results, known cardiovascular disease with worsening symptoms, documented cardiac complications during COVID-19. They had pericarditis or they had an MI or whatever, or persistent unexplained cardiopulmonary symptoms after 12 weeks. Then you have to send them just to make sure. But probably the cardiologist is not going to find much more than what you did. Next. This is important, 3 definitions. Orthostatic control, because a very common, especially in the females, is that they come, that I get up and I get dizzy. So you need to make sure if that's intolerance, if it's truly orthostatic hypotension, or if it's POTS, which is postural orthostatic tachycardia syndrome. So orthostatic hypotension has a drop in blood pressure, and postural tachycardia has an increase in heart rate, but doesn't have a drop in blood pressure. You can do that in your office with, and I'll show you one complicated way, but the simple way is just lie the patient down, take vitals, have them sit, take vitals down for 3 minutes, have them sit for 3 minutes, take vitals, have them stand up for 3 minutes, take vitals, and then you can put them on these categories. Next. And next. So this is one test. It's called the NASA lean test. It's a little bit more complicated. It takes a little bit more work, and it's probably more sensitive than the one that I mentioned. You lay down, sit, and stand for 3 minutes in each place, but probably you'll get a better evaluation of what's going on. But when you look at the details, it's really not complicated. You just have probably to train your MA or your nurse on how to do this. And when the patient comes in, just do it, and you can get a good idea of what's going on. Next. So there are non-pharmacological measures, which is, minimize alcohol, good hydration, avoid heavy meals, avoid caffeine, alcohol. These are all general measures that you can tell the patient, which especially have this dizziness standing up to try to take. Next. And then you have pharmacological interventions. So you may be comfortable with one or many of them, or maybe you need to send them to a specialist, but you're going to have so many patients with these problems that I would encourage you to start reading a little bit about them. And what we use in our clinic is for POTS, which we've seen a couple, is beta blockers. We have for people with just feeling very tired and weak, and the postural thing is we use fluorocortisone. And we just make sure to revise any other medications that they're taking that could be exacerbating these symptoms. And if you can't figure it out, send them to the cardiologist, and they'll do a tilt test and a more complicated test and put them on treatment. Next. So finally, COVID is here to stay. It's been 2.5 years. We're still wearing a mask. American Indians, Alaska Natives are disproportionately affected. the most effective way to curb the pandemic is through vaccination. We're not going to treat ourselves out of this pandemic, but we may be able to. If everybody had gotten vaccinated 2 years ago, I don't think we would be where we are right now. But we still have a chance. If we have a good COVID booster and everybody would uptake it, which I doubt, it would be a way to curb the pandemic. But of course, contact tracing, testing, isolation, all the other measures are important and have their role. And we have effective treatments. I don't think anybody should die of COVID today, because if they have COVID, you can prevent it in the majority. If they get it, we have a lot of treatments. And even after that, you would have to be very unlucky to die. I mean, there could be a handful, but we have a lot of ways to prevent death. But this will require a big effort from us, the patients, and the community overall. And I'll stop there. And if there's any questions, I'll be happy to take them.
Questions for Dr. Mira? This is your chance, because I mean, as you can tell, he has a lot of expertise.
So, you know, we will have patients that get the monoclonal infusion, things like every 9 months. But they may get monoclonal infusion like once every 9 months, because they're not vaccinated, but they're high risk and they get COVID more than one time. What are your thoughts about that?
Yeah, no, I mean, I agree with you and I feel your pain. And actually, there was a moment in which we didn't have enough treatments to give everybody, and we had to select the non-vaccinated, because they were the ones having worse outcomes. And it seemed counterintuitive. The vaccinated were very frustrated. So I don't miss, at the beginning, I would try to convince them that I'm saying I'm not getting anywhere, so I'll stop. But then I went back and said, no, we're health care providers. They're here for a reason in our office to say on the urgent care. I should give them the best information, and they'll have to digest it and come up with whatever they want. But I'm not going to just be silent because they're doing the wrong thing. Like everybody who smokes, you tell them you should stop and give them treatment, and at least you do that, right? So what I tell them is this, because the answers that I get is usually, well, why are you not vaccinated? Well, I don't want to get these, these things are investigation. And I tell them, what's really investigation is what you came for today. Because that does not have enough proof compared to vaccines. And so I give them that type of spiel, and I try to raise their community awareness and say, if you get vaccinated, you're protecting your neighbors, you're protecting the old person. Like when you go to the supermarket, those people will die. Not everybody has access to health care like you do. And I try to, instigate a little bit of, go to their hearts a little bit. Now, I can't tell you what the impact that has. Because not of them, okay, they will have to come back to vaccination a few weeks later. I don't know if they came or not. I do remember one person after a long conversation saying, yeah, okay, I'll get the vaccine. And it wasn't a monoclonal, it was a different sort, and they went and got it. So it takes a lot of effort, but if you can convince a handful, you're doing a lot of good. So I would do the effort. And it's very interesting how people think. Like I had a patient that was treating that day for HIV and Hep C, an active injection drug user. He was there for that reason, not COVID. So I said, did you get a COVID vaccine? He said, no. And I asked what? Well, I'm just afraid of the side effects. And I go, okay, I don't want to judge. If you fight heroin every day on the street, and you're not afraid of those side effects, well, why are you afraid of this side effect? And I try to be very polite, non-judgmental, but try to put things in perspective. You are taking many risks with what you're doing, and it's fine. I mean, it's your choice, and we're here to help you. But give me a better explanation. And that's the one who got vaccinated. Yeah, I never thought of it that way. So 2 weeks ago, I got vaccinated. So I would just insist. And I do have a question.
I was just going to ask, what do you think about anyone being more lenient than we should be?
Sorry?
Being more lenient than, CDC guidelines and state guidelines. Where do you think that causes issues? I don't know if any tribes have, like in the USET area, but we had, the full sovereignty to, say within our territory, COVID doesn't exist. That I know of, no one has done that, but I know some have, you know,
Or the downgrade to recommendations, you mean?
yes, you know, not, upheld like the mandation of vaccines for like certain sectors, like healthcare or daycare, where we have the NLBL sovereignty to not do that.
So your question is, what do I think of that?
Yes,
Well, it's my personal view, of course. I mean, I am a healthcare provider and I go by the science that I read. And of course, the science can change. And like I was telling you 2 years ago, I was telling people, this is not aerosol. Now we know it is, right? So I will admit that we're not perfect and we have mistakes and we correct them as soon as we can. But I think we should act on the science. The problem that I'm seeing, and I don't have everywhere, is that decisions are made on political basis. We have an election soon, and I'll get the maximum amount of votes. And if I do this, it's going to be unpopular, and it may affect. And that's not right. I mean, I think that healthcare decisions should be made by the healthcare system, public healthcare system, state health department, basically, but not on the influence of the governor or mayor or whatever. It should be, this is the best decision we have based on science. And explain it clearly to the people. Sometimes we can be very confusing in our messaging. And so people don't understand why we're switching from one to the other. That's also something we need to improve. But I believe that we would be, everybody would do what we're doing right now.
Wearing a mask in a meeting.
Have much less COVID than we, I don't have that about.
Anna, what, did you have a question?
Yeah, right. But I think these should make strong recommendations. I mean, in this country, liberty is, or free decision is praised. We can't enforce many things that can be done in other countries. I mean, I'm not saying it's they're bad, giving you the facts, that's the reality. So, but at least we should make clear, strong recommendations. Like we recommend that because of the level of activity of COVID right now, everybody in schools should be wearing masks. Everybody who can wear a mask. Everybody, we should be testing more frequently. We should be, I go to Europe frequently, my daughter lives there, and it's so easy to get tested. You walk 4 blocks and you have a center, you go in, you get a test, and antigen, you're done, it's free. So people, when they have that option, they do it. And someone who's positive is not going to be exposing other people on purpose, in general, 99%. So I don't think we've done enough on that sense. I don't think we've done enough on testing, using antigens to test. The anecdote I was telling you, what I found out getting infected, we went to a wedding in which the day before the wedding, the bride knew she had COVID, but didn't say anything, and met with all the bride community for inside a house for 8 hours practicing. And then 3 days later, she gets COVID, and we find out. And by that time, everybody had it. So there were mistakes on both sides. The person should have said, you have to cancel because I have COVID. Second, they should have all wore masks indoors, and then that would have been the preventive measure. So it's, you can't blame all the blame is not on one person. It's usually several mistakes were made. But if we would follow all those guidelines, I think we would be a little bit better off.
Anna?
I'm sorry, I'm a little bit stuck. Can you?
However, for the future longitudinal studies with COVID and how our home tests will impact those studies.
So longitudinal studies of looking at one in particular.
And COVID risk factors for other diseases and how the mechanism of COVID long-term on the body.
No, I think that the use of home tests is, I think it's proper if we have high levels of activity in the community, not with low levels, because when low levels, the home test can have false positives. And the sensitivity will be very low. But if you have high level of activity, I think, periodically using home tests, especially if the household has exposures, it's good because once a household is determined to be infected, you can isolate them and protect the rest of the house. Because with Omicron, if you don't quarantine, 4 out of 5, people in the household will get infected. It's much more than we were seeing with Delta, and we would see one household. So I think that's the value of the home test. If we do use it routinely, but the problem is the cost. So I want to do a home test, I have to pay $10 per test. That's for a family of 4 or 5, it would be $50 each pot. And if you're trying to do that once a week or twice a week, it's impossible. I think that's one of the things that needs to be solved in our country. In Europe, it's $1 or $2 a test compared to $10.
How lack of that data tracking more
Yeah.
impact on understanding how.
Oh,
So-
back up, okay, I'm
Yeah.
sorry. I don't know how that, I mean, it's certainly, like the numbers that we're seeing now are underestimated, because these are based on, laboratory tests, or antigen tests done in laboratories. So, but I don't know, I don't have a good answer for the question. I mean, I'm sure it's gonna impact, but I don't know how much or what you could mitigate that. Except that you would have home tests that you could report. Like there was one home test, the Illum, it was an app, and you did it with your phone, and you would send that report, so other people would have access to that. Or you can use an app to voluntarily report, and it would tell, but I'm not sure how people would, if people would do that. I'm sorry.
Yeah, what we really need is just a mobile phone app that goes directly to the CDC data, that would report and that people could do in 30 seconds or less. That's what we need. I don't know if we'll ever have that, but it would be very nice, just for the reason you're saying. I mean, the big downside that I see to home testing is that we are undercounting by a lot. Some people think up to 14 times, which, so maybe we're not having 100,000 cases a day. Maybe we're having 1.4 million cases a day right now. We don't know.
Yeah, and the other cool thing I've seen done with apps, I was recently in DC, is that they ask you if you want to participate in their contact tracing. And because of, if someone tests positive, and of course they report it, they have their cell phone, they can see if that cell phone was near you for a certain amount of time and that you could have had an exposure. And they're communicating. That seems like really cool and useful. At least I would like to know if I was exposed, and maybe I take more measures and get tested more frequently or protect myself or my family. But I think that there are many tools that we could use. I just don't think we're exploiting them. And I think there's a COVID fatigue everywhere. And now we have monkeypox, so we have something else to worry about. But yeah, thank you for the question. Oh, yeah. Yeah. Yeah, you're being followed, but you're always, if you have a cell phone, you're being followed. Don't worry.
So I think Dr. Mira will stay around for a little bit if you want to ask him questions or talk, but we're pretty much over time. Dr. Mira, thank you so much.
Thank you.
And USET would like to present you with just a small token of appreciation here. Just some reminders. Before you exit the conference today, we have some networking opportunities, of course, but we also have a raffle that we're doing for the next 15 minutes, and you must be present to win. That includes the virtual people too, I think, but otherwise we look forward to seeing you tomorrow. We do have some evaluations. If you could possibly fill those out, we'd be very appreciative. But otherwise, thank you very much for your attendance, and hope you have a good evening.